So, Dr. Chandrasekaran, why don't you start off by giving us a quick introduction about yourself and how you got to where you are today?
Yeah. Hi. Thank you guys for having me. So, like they mentioned, my name is Neena, Dr. Chandrasekaran. I usually tell my patients my name is Dr. C because it's 14 letters. But I started out, I guess, back when I was like way young. My mom's a doctor, and I got exposed to the medical field very young. So I was always like, okay, this is something I want to do. Through elementary school, middle school, high school, I was pretty involved with different clubs, community outreaches, working in the hospital for volunteer hours, going to my mom's clinic and my mom's friend's clinic who would have me, and kind of just getting myself more exposed into the medical field, learning some terms here and there, seeing the interactions, seeing pretty much what they did. And I was like, wow, this is so cool. I want to do that. So, with that in mind, I kind of geared my high school towards undergrad med school. I did apply to some of the 7 year or 7 and 8 year direct programs for med school, and that gave you into undergrad and then straight into med school. There were certain requirements that you needed at the time, and I was able to apply. And so I did not end up doing that, but I did go. Because of just personal reasons, I chose to stay in Fort Lauderdale, close to my parents. So I did my undergrad at Nova University. And afterwards, I did my med school in Antigua, AUA, American University of Antigua. So I took the Caribbean route. I was in the Caribbean for 2 years for my basic sciences, which are our med school classes. And then the other 2 years for my clinicals, I did my third year at FIU, Florida International University of Miami, and then my fourth year in New York. So I got a good mix and feel for just different places, how different places practiced, and I felt very comfortable and very well, and just I didn't feel like there was a difference in terms of my education, if that makes sense. So then I did my internal medicine residency at University of Pittsburgh Medical College, so UPMC. It's in Pittsburgh, Pennsylvania, and now I am in Wayne State, Detroit, for my fellowship, Pulmonary Critical Care. So I'm second year, and it's been pretty crazy. Pulmonary critical care, I chose this because when I was in med school, I didn't really know what pulm crit was. I knew what pulmonary was because this is just a study of lung pathology essentially. So anything from asthma to COPD to interstitial lung disease, pulmonary fibrosis, pulmonary hypertension, pretty much anything with the lungs. I was like, okay, that seems pretty cool, but I wasn't really into it. Then in my fourth year, I was able to do a rotation in the intensive care unit or the ICU. And I was like, wow, this is nuts. So each intensive care unit, you're basically on the brink of death if you're in the ICU. You're very sick. They only admit like the sickest of the sick. You're on the tube, like you're vented, intubated. You have a lot of pressors going through. You're on like 6 drips, 5 drips. So you're really sick if you're in the ICU. And then and they also run all the codes. So if somebody has like a code blue or like a heart attack on the floors and they scream out for a code, the ICU doctors are the ones who usually run those codes. So I got to see that, and I was like, oh, these doctors just know everything. They just ran, they were able to just run the code so quickly. They were taking care of like every single aspect of the patient, and I was like, this is very interesting. So it really drew my interest, and that's what kind of gauged my internal medicine residency. I was like, this is what I want to do. I want to go into critical care. But then while I was in internal medicine, I was able to do pulmonary. And so I got to see the best of both worlds. And I was like, and just going into critical care, you can do that. So you can very well do internal medicine and just do critical care and just be in the ICU. But there's something with a lifestyle balance with just critical care that can get difficult. You're working 12 to 14-hour days. You're always on your feet. You're running codes. You're intubating. You're doing a bunch of procedures. It's not like surgery where you're going to do an open heart or like open the body, but you do surgical procedures, like you do lines, subclavian lines. You can put in chest tubes. We intubate. We do arterial lines. We do lumbar punctures. So we do a bunch of procedures. You're doing that constantly. So between that and then you have a lot of sick patients that you're taking care of. I was like, okay, this seems like it will be a lot. So I'd like to balance it out with another specialty. So pulmonary critical care kind of go hand in hand. And pulmonary is like I was saying, it's the study of lung pathology. So the way pulmonary critical care works is you spend half your time in the ICU and then the other half in pulmonary. And with pulmonary, there's outpatient and inpatient consults. Inpatient consults could be like somebody has COPD on the floor, somebody has a pneumonia on the floor, somebody has a lung nodule on the floor. So something like that, sarcoid, asthma, pulmonary hypertension, we see all these patients. And you also get the best of both worlds because you also get to do clinic as outpatient. So you get to grow a relationship with these patients in the outside sector of just the hospital. And I appreciate that you get to be as heavily involved as you are in the ICU, but you also get to see them in clinic. So I was drawn to that, and that's how I ended up in pulmonary critical care. So what I normally do is it depends on which rotation I'm on. At the moment, I'm only on pulmonary outpatient. So pulmonary outpatient every day, Monday through Friday, we go to a different clinic. So today I had general pulm. So general pulm usually entails a COPD, asthma, and ILD, interstitial lung disease. Tomorrow I have just asthma clinic. So I'm working with patients that just have asthma. So you get really good at these. Wednesday is sarcoid clinic. So anybody that has sarcoid, you get to just kind of deal with them and get really good at that. In the sarcoid clinic, we also see other interstitial lung diseases. So lung diseases that are associated with Sjogren's disease, scleroderma, lupus, we get to see them. We get to see those patients and treat them too. Thursday is lung nodule board. So anybody that has like a spot or a nodule or a mass on their chest from smoking or a family history of lung disease and they have cancer, or metastatic lung cancer or some mets to the lungs, we get to deal with those patients on Thursdays. And also pulmonary hypertension clinic is Thursday. Friday is my general pulm clinic with my patients that I get to follow up with. So I love that. I know who they are, they know who I am, and we build a rapport. And it's great to really treat them and see them as a first year and see them kind of progress. It's a really good feel. The weekends, sometimes I'll have ICU shifts that I'll have to cover. So when I'm on the ICU, which I will be in December, those days are way more intense. We start our days at 6 a.m. So we're up at 5 a.m. Get ready, and we are at the hospital by like 5:45. We take sign up from 6 a.m. till like 7:15, 7:30 from the night person, and then we carry our pagers, and then any new admissions that come in, we'll be admitting. Anybody that needs emergent lines or procedures, if we need to intubate them, if we need to place a central line in them, or start them on any medication, we will do that while rounding. And that's pretty much the day just flies by. And by the time you're home again, it's like 7:30 or 8 p.m. and you're like, oh, tomorrow's another day. So it's pretty busy when you're on the ICU. I'll be doing nights from December 1st on, so I'll be ghost. But besides that, it's pretty cool. It's a good balance. So I definitely like what I do. I can't see myself doing anything different. I think with COVID, it's been busy and different than any other pulmonary critical care specialty or fellow has gone through this year more than any other years. It's just been so different, and practices have changed, not only in my realm, I would say in every single realm. Every healthcare provider has seen it, faced it, and has changed their ways in one way or the other.
Mm-hmm. Yes, so you definitely answered what you do day to day. That sounds incredibly busy. So like, did you have a hard time adjusting to that when you first started?
Yeah. So when I first started fellowship, it was a lot different than internal medicine residency, because in internal medicine, you're working with everything. So you don't focus on you focus on the bigger picture, but on a more non-critical level, if that makes sense. So when I'm in the ICU, it's somebody is dying and I need to fix them so they don't die. On the floors, you're just stabilized. It's something very stable. It's like they have a cellulitis, or they have a very simple pneumonia that they just need 5 days of antibiotics for, IV antibiotics. When in the ICU, it's like it's a lot more critical. They need blood pressure control. They need they need to be vented. They need to be you need to work on their settings to get them off the vent. You need to figure out what specific antibiotic they need. Sometimes you have to take like a scope. We called it bronchoscopes. GI does endoscopies and colonoscopies. So they go from the mouth into the esophagus, and then GI goes from the colon, from the rectum to the colon above. We do mouth through to the lungs. So we do bronchoscopes a lot on our vented patients and see if we can get a sample from their lungs. So then we can test in the lab to see what specific antibiotic to put them on to help them. So it's very critical in the ICU. For the pulmonary part, coming in after residency is also different, was very different for me, because I was used to controlling everything. I was used to controlling the blood pressure. I was used to controlling their blood glucoses if they have diabetes. I was used to controlling just every aspect. But for pulmonary, you're only focused on the lungs. So like even if this patient has a blood pressure of 200 over 110, I'll mention it, but I won't do anything technically about it because that's not what I'm there to do. I'm there to listen to the lungs. If they have COPD, they have wheezing, then we switch up their inhalers, make sure they're on the appropriate inhalers. If they need further care in terms of oxygenation, if they need a blood gas because they seem a little altered or their CO2 is a little high, they have obstructive sleep apnea and they should be on CPAP or BiPAP. That's pretty much like what we do and we take care of on the floors in terms of pulmonary. We do procedures sometimes on the floors, like I was telling you guys, the bronchoscopes, we do those. And then we also do thoracentesis, where if somebody has fluid in their lungs, we'll just take a needle, put it to their chest and just remove the fluid, just drain it there and then.
Wow. Nellen, would you like to ask the next question?
Oh, yeah. Sorry, my mic was just being weird.
No, it's okay.
So that sounded incredibly technical. So in learning about that in med school and in your time in pulmonary and critical care, were there any outside major challenges you had to overcome? And if so, what were they and how did you overcome them?
Specifically in terms of what? For any specific challenges?
Yeah, academically, maybe even in that environment with colleagues.
Yeah, that comes up a lot, especially in just the medicine field as well. I would say there's a lot of competition. A lot of people just who are medicine minded view this as a competition. Like, I need to get in compared to this person. This person's in 6 clubs. I need to be in 8. And we're kind of trained that way to an extent, I would say, because you always have to be the best to get in. You have to be number 1 or top 10% or this and that. And I don't think I was any of those. I did go to medical school in the Caribbean. That was a choice that I made based off where I was and where I think I would perform. My cousin had gone to the Caribbean and did really well. And so my parents were kind of like, oh, okay, your cousin went there. Maybe you can go there too. And I was like, okay. But also, you have to, there's always the MCATs to get and then do well on to get into a med school. There's like the ACTs too that you can take, I believe. And there are just a lot of obstacles in the way of when you are in high school that you feel that you just have to push through and get through and kind of compete with each other. But that's really not the case. Med school is more about hard work, I would say, compared to being number 1. If you are a good person who can work hard, that's probably better than the most smartest person. Nobody likes to try to teach somebody who thinks they know it all. It's better to teach somebody who will just work harder and just kind of improve upon themselves. So my specific challenges when I was in undergrad, I was like, oh my God, I need to get into med school. I need to do something that will set me apart from everybody, just like I'm sure all of you guys think too, to get in. I started a club when I was an undergrad called Children at Heart. And basically it was an organization on campus. We would go to local children's hospitals on holidays and we raise money to bring them just like construction paper, little gifts, markers, and just a bunch of like arts and crafts supplies, sandpaper. We did sanding. We brought them a bunch of like little arts and crafts activities and we would do it with them. So the point of it was to kind of bring joy. So Children at Heart, we would just bring joy to them and we did it on every big occasion, like Christmas, Valentine's Day, St. Patty's Day, 4th of July. And that was on my application for sure. And I was part of sorority in undergrad as well. So there was that. I was president of my sorority, my chapter, and we did throw society organization events as well for the community outreach. And then a lot of that did take away time from studying, though. I'll tell you that much. I maintained somewhat of a good, like 3 point. I was between 3.7 and GPA, but besides that, you just need good letters of rec and good people around you. You need a mentor. If you get a mentor, then they can help you with research. And getting in on research, I would say, is big these days, especially the way everything is kind of trending. I mean, here we are virtual, and I do know a lot of med students that I work with who are when I was in clinic today, I had med students and they were telling me that this might be their last time that they're here in the hospital because of the rise in COVID cases. So a lot of them are now transitioning back to virtual, which puts them kind of, I know that a lot of them are nervous. They always tell me, they're like, well, if we're not in the hospital, how do we meet people? How do we meet attendings? Who's going to know us when we apply? There's a lot of obstacles and challenges, I think, that are going to be faced even more. But putting yourself out there, reaching out to people through email, I think is great. And that's what I was telling them. I'm like, even though you're not going to meet them face to face yet, you can still make that introduction. You could still send out an email. What's the worst that can happen? They don't respond. At least you tried. Give them a little intro about yourself and tell them that you're interested in research. And maybe if you propose an idea to somebody and they like the idea, they will go for it. That helps a lot in the person who's proposing the idea and would like to join research and the person on the receiving end. I actually had a few med students who did reach out to me to do some post-COVID research, and I thought that was awesome. I was like, yeah, this is a great thing to do. And I helped set up the IRB and everything for them. So we're going to be looking at post-COVID, our patients that get COVID and who are very sick, what happens to them in terms of their lungs afterward. So I would say that there's definitely obstacles along the way, but you can overcome them if you have a plan to do so. When I was younger, I I didn't think I would be telling myself this back then. I would be like, oh, I should have done this, I should have done that. But at the end of the day, I mean, so my husband, he went directly the 3+4 program. So he did his undergrad, same place as me, and he went straight to med school. So he stayed at Nova for med school. He was in an American med school. And today he's a practicing internal medicine attending, but he's where he wanted to be and I'm where I want to be. There's nothing that would have changed if I went to an American med school. Mm-hmm. So it doesn't really matter where you go. It's what you make of it when you get there.
Okay, so we have one last question before we start the Q&A session. And the question is, what information do you think that high school students should know before committing to this career path?
That's a great question. It's a great question. Pretty loaded. With COVID these days, it's hard to say what's to come. Who knows if we're going to get another pandemic? Nobody expected this. Doctors have been practicing for 60 plus years. My mom's been practicing 40 years. She didn't even realize this. Medicine can take a turn at any minute. There's new technology. There's a lot of new artificial intelligence now too that's being created for different procedures even, they're saying. So I think that high school students who are going to pursue medicine, think long and hard if this is something you want to do. And if it's something that you want to do, then 100% go for it. We're going to need a lot of doctors. With things like COVID, it's not ending anytime soon. We need good people who are out there just helping the community and really protecting people from what possibly could come, what's to come, and what's going to be the outcomes of this. Think long and hard about it and pursue it. We need more good people out there. I would also say one big thing is another thing to consider is research too. That's going to, I think, be a game changer in the next coming years.
Yeah, for sure.
Thank you so much for your advice and your inspiring us and showing us how critical it is for people to be in medicine. And now, and thank you for answering mine and Vanchika's questions so thoroughly. You told us so much. Now we're going to open up the floor to other attendees here with us in our Q&A session. We have about 5 to 10 minutes. So Vanchika is just going to quickly go over how we're going to conduct it and we can get started.
Yep. So what we're going to do is if you would like to ask a question, you can just put it in the chat and we'll read it out loud for you. And if you would like to personally ask a question, just raise your hand and then wait to be called on and then you can unmute and ask. So, yep.
So how do you deal with the stress in the ICU? Like, you're dealing with patients who are like suffering and like are about to die. So just like one mistake, it's just like, isn't that like really stressful? So how do you like handle that?
Yeah, that's a great question. I would say that it gets better as you go through and you learn mistakes. That's kind of hard to say, but it's true. I mean, you don't have a choice, if that makes sense. When I first started, I remember my first night shift ever. I was in Detroit, here in Detroit. I've never been to this hospital before. They gave us a tour, whatever, but I still didn't know where anything was. And there was a patient who had a carbon dioxide level greater than 100. It was like undetectable, and he was just somnolent. And so all the nurses were like, "Oh my God, he needs to be intubated. He needs to be intubated. Why aren't you intubating him?" And I'm like, "Crap, I need to intubate him." But I didn't know. I wasn't very comfortable too yet. He's an obese guy. His Malin-Patty was like 3. He had a big neck, and I'm like, if I try to tube this guy, I might miss, or I might not get it. So I'm like, okay, let's just put him on BiPAP. And I call my attending, and I'm like, oh crap, I think we need to intubate this guy. And she's like, okay, call anesthesia, have them intubate. And I was like, okay, good. So like I called anesthesia, they came, they intubated him, and he was fine. But it's just things like that where you go through something and then you know what to do because you went through it. So because I went through it, my next patient the next night who needed to be intubated, I'm like, okay, he was easier to intubate, so I was able to intubate him. But then the following night, I was not able to, so I'm like, okay, let me just call anesthesia. So you live and you go through it. Experience guides very much. It is stressful at first when I don't know what to do, and it's kind of being thrown at you at once. It is stressful, but you learn to compartmentalize, and you learn the worst thing that can happen is you tube them, you miss, and you keep bagging, and you call anesthesia and they come and they tube. And if you tube and you cause a pneumothorax, then you place a chest tube. It's things like that. It's like the worst case scenario in your head that can happen, you can fix it. So once you know that, then it gets better. I used to always think, oh my God, I don't know what I would do if someone's bleeding out all on me. And that happened. I had a patient that was in DIC and he was bleeding from like his nose. He had blood in his ears. I didn't even know. I was like, wow. He's blooding from his mouth, just like he had a GI bleed too. It's just like, oh man, this is bad. And then you kind of keep like a level head. That's the biggest thing, keeping a level head, because everyone around you will not have a level head. They'll be like, doctor, what do you want to do? Doctor, what do you want to do? Doctor, what do you want to do? And I was like, okay, let me just think about this for a minute. Let's make sure it always goes back down to like the ABC. So airway, breathing, circulation. As long as you make sure that they have a proper airway, whether it's a tube or a crike or a trach, or you're bagging them, whether they're getting their oxygenation. So airway is number one, then breathing, airway, breathing. So that's part of the same thing. And then circulation. So you make sure that they have a blood pressure. So once you remember those in your head, things become kind of straightforward / second nature. The worst I can do is this, and I can fix it by doing this. If you give someone too much insulin, you just give them more glucose. You tell them to take a sip of orange juice, and they're fine. So it's like it's something that you learn as you go through experience, I would definitely say.
All right. So the next question we have in the chat is, what were some things that you felt made you stand out as an undergrad applicant or med school applicant?
So in high school, as a med school applicant, that would be what I did in undergrad. But as a high school applicant, that made me stand out for either the 7-8 year program or undergrad, I guess. I went a lot to my mom's clinic. I think that helped a lot because so I was getting a lot of hours that way. I was able to get into research as in high school, so that definitely helped, I think. So I was able to speak on it. And when you're in high school, it's a little difficult to get into research, but if you're able to, if you have connections to get into research, that definitely helps. Applying here and there for certain scholarships can help too. They have like those ones you can like look up if you write a book, or if you read, or if you just write an essay to something. That kind of gets you to stand out too, because nobody really does that. So that's pretty cool. Maintaining a good GPA. Maybe try to start a club in high school. I did that in undergrad. I think that's very cool. With COVID now, I think you can try to organize some things here and there, kind of like you both are doing with this right there, which I think is great. And a lot of other different Instagram things I've seen a lot of people are doing. There was this, when COVID was bad back in March through May, there were this group of pre-meds that helped us, like the healthcare people. They helped us by getting our groceries, kind of delivering things that we needed. So they put that on their application. I bet they did. So just like if you can think of things like that nowadays, I think would be huge. And it's going to be things like that that are going to set people apart.
Okay, so the next question is, how bad is the situation at hospital regarding PPE? Is there still a shortage on masks and other items, or are those resolved now? What are the most required things at your hospital that are still not available in enough quantity?
So PPE isn't banned in my hospital. So we go to 4 different hospitals here. It's kind of like a large system. One of the hospitals, it's pretty bad in that they only give you one a day, which, I mean, that's fine. So I'm also talking from the ICU standpoint. So my standpoint is going to be a lot different than people on the floors, because in us in the ICU, we get the highest viral load exposure. We're the ones who are placing the lines in these patients. We're the ones who are going to intubate them. And when you intubate, you're getting direct viral exposure because you're putting a tube in someone's mouth, and that tube is going straight to their lungs. So all that air they're blowing out is going to get in your face, and you're going to get exposed. But at that point, we're wearing all PPE. So in the ICU, I would say it's not bad, but on the floors, from what I'm hearing, it is kind of bad in that they are only giving you one a day. And a lot of my nurses are telling me that they're only getting one for every 3 days, which I think that's kind of ridiculous. I think that's actually very ridiculous. They're trying to, I think they're saving the PPE for like December and January for when it's going to get bad. It's pretty bad now, but it's going to get worse. I don't think it's going to get better yet. We're on there.
All right.
But I don't know.
All right, so the next question we have, and okay, there's 2 questions in the chat, so those will be our last 2 questions. The first one is, can you explain more about your day-to-day life at residency?
Yeah. So residency was different. So residency, you have a bunch of different rotations. You have a schedule for 12 months, and in that you get a different rotation every month. The majority of the 12 months will be floor months. So it depends on what type of residency you're doing. There's derm, neuro, urology, surgery, psych, family medicine, internal medicine. Depending on what you're going to go to, you'll get like a different schedule. But I'll talk from my side. So my side was internal medicine residency. And because the bane of internal medicine residency and like the main part of it is internal medicine, that's where you're on the floors. So you're on the general medical floors, and at least half of the year you will be on floors. When you're on floors, basically that means you're admitting patients to 7th floor, 6th floor, 5th floor, 4th floor, all the floors in your hospital. And you're taking care of kind of acute problems. And the reason I'm saying kind of acute is because I'm really used to the ICU. So the ICU, everything is like stat acute. But you're taking care of post heart attack. You're taking care of diabetic, keto, high blood glucoses. You're taking care of cellulitis. You're taking care of pneumonias that can be managed on the floor. You're taking care of seizures. You're taking care of things like that. So pretty cute things that need management now. So then that's why they're hospitalized. And when you are on the floors, your day usually starts 7 a.m. and you're there until 3 managing your patients that you have. So if your service has like 14 patients, you'll round on all 14. You'll talk to them, their families, whatever they need to be taken care of, you take care of. And your goal is always, when can I discharge this person so you can get the new person in? So you're always thinking ahead. What can you do to kind of let them go, but make sure it's a safe discharge at the same time? And what can you do to admit that next person? Because it's always a rolling ball game. You can have a whole 14 patient list, and the next day you can have like 5. Then the next day you can get a whole new 14 list. So that would pretty much be what we do mainly on internal medicine. And in internal medicine also you get specialty. So the rest half of your year is going to be different electives in different subspecialties. So you can do a month of cardiology where you're doing cardiology, you're seeing cardiology consults. So anybody who has an arrhythmia, bradycardia, tachycardia, atrial fibrillation, they will consult you as cardio. Then you can do a month of GI, gastroenterology. So you're going to see GI consults, stomach pain, inflammatory bowel disease, upper GI bleed, lower GI bleed, cirrhosis, alcohol drinking, hepatitis. So that could be a month. And the next month you can do ICU, which is what I do, or pulmonary, which is also what I do. Or you can do neurology for a month. So it's pretty cool in internal medicine. I really like that you're able to do it all. I think that that's great, and it really gives you a footing into helping you decide what you want your next step to be. You don't always have to go in knowing what you want to do. I feel like for me personally, it helped me because I was able to start research early on in what I wanted to do to help my chances, and I was able to connect with the people I wanted to. So then I would know, because time moves very quickly. You're studying, like when you're going home, you're going to be like, okay, today I saw hypertensive urgency. Let me read up on that. Or I saw a cellulitis today. How do you manage cellulitis? And then you read up on it. Every day you should learn something new. If there's one thing that I learned in residency is read up on what you see and learn one thing new, even if it's just what the criteria score is for necrotizing fasciitis, or what are the antibiotics you use to treat healthcare associated pneumonia versus community acquired pneumonia, things like that. Anything you just learn. It's hard to sit there and read, but if you learn by experience, learning by what you see, that really helps.
Okay, so the last question is, do you need to complete all your med school prereqs before applying or before attending med school? What if you have a few 1 to 3 prereqs left to complete?
You don't have to finish all of your prereqs before applying to med school, because you still have the rest of the year. And then you can also you can do post-bacs and take them during the summertime if you need to repeat it, or if you need to get your credits though, most of them at least, unless you're enrolled in the credits for the next half the year for applying to med school. And every program is different now too. UAB and a couple schools in California don't even require MCATs now. So that's definitely something to look into.
Okay, thank you for all the questions. We have reached the end of our meet, so we will not be taking any more. But if you didn't get to ask your question, you can email Dr. Chandrasekaran, and she can also take questions by DMing her on Instagram. So definitely go ask those. Yes, thank you. And I just want to say thank you for being here. It was so great to have you. You definitely gave us so much advice, and we loved hearing about your experiences. This is very interesting. But yeah, thank you. We're so grateful to have you here.
Of course. Thank you guys for having me. This was great. Like they mentioned, if you have any other questions or something that I wasn't able to answer, please do feel free to DM me or email me. Mm-hmm. Nice talking to all of you guys. Have a great day.
Yes, thank you.
Thank you. And just as a reminder to everyone, this meet will be posted on our website under the virtual meets library. So if you have any friends who weren't able to attend, please direct them towards this recording.
Yes. Bye. Yes, bye. Thank you.